Endocrine, presented by Dr. Cord Surgeon, Associate Professor of Surgery, Director of Endocrine Surgery at Northwestern University Feinberg School of Medicine. Please give a warm welcome to Dr. Surgeon.
Thanks. I've got about an hour and a half to do about 250 slides, so we're going to go pretty fast. Plus, I understand tonight's the beginning of the NFL season, so we got deadlines, we got commitments. All right, so we're going to go through this lecture pretty quickly. This is my CME disclosure. I have no disclosures to make. We're going to go through all this stuff. So we're going to hit the highlights. I think the big ones are thyroid nodules. That's where a lot of the testable questions are. Hyperparathyroidism is pretty hot right now. We just had a set of guidelines published, so we'll hit those especially. So to start with thyroid nodules, step one, figure out what nodules you're going to biopsy. Don't biopsy every single nodule that walks in your office. You have to be discriminatory. You have to think about those nodules that have the highest pretest probability of cancer, okay? And you generally are employing a nodule to try to discern whether something is or isn't cancer, but you're also sometimes trying to decide if something needs to be done about a nodule or not. This obviously, you know, is not what I'm talking about. This person's getting that thing out. Yes, it's going to have a biopsy. But where I find myself kind of in the weeds more than anything else are these incidental nodules. So when you walk into the ER with a sprained ankle, you're probably getting a whole body scan, right? That's the way it is where I work. So we find a lot of these things. These incidental discovery of thyroid nodules are extremely common. They're found on ultrasounds, CAT scans, MRIs, PET scans. You get a carotid duplex. They find one. They're all over the place. And most of these, yes, are benign. Probably 95% of nodules that are out there are not cancerous, but it doesn't mean you can blow them off. You have to decide, does this need to get biopsied or not, and what do I do about it? So the first thing you do is try to figure out if a person is more likely to have cancer than somebody else. So you're looking for those risk factors for thyroid cancer, like radiation exposure, especially to the head and neck area, especially in childhood. What we've learned from Chernobyl and other unfortunate events like that is that the probability of developing an abnormal thyroid and the probability of developing thyroid cancer are related to the age that you received the radiation exposure and the dose that was given. So the younger you are and the higher amount of radiation that you receive, the shorter the lag phase, the greater the probability that something bad is going to happen. We also know that in people who had a significant exposure to radiation to the head and neck area, that they not only got abnormal thyroid glands and thyroid nodules and goiters and graves and thyroid cancer, but they also got more hyperparathyroidism and more salivary gland tumors and maybe some acoustic neuromas and other head and neck type tumors. In general, a good rule of thumb that I've used in the past is if a person has a significant exposure to head and neck radiation, especially as a child, and they now harbor they now have a multinodular gland, some type of abnormal thyroid gland, then the probability is about 40% that we're going to find some type of thyroid cancer in those glands, especially if they're in the proper lag phase, about 30 to 35 years. A family history of thyroid cancer is pertinent also because about 6% of all papillary cancers are inherited, although we don't have a clinically available genetic test for that right now. It is a reasonably common finding, 5 or 6%. Family history of thyroid cancers, also, of course, about 25% of medullary cancers are inherited as well. So if a person says, yes, I have thyroid cancer in my first-degree relatives, then that could be a significant risk factor, whether it's a follicular cell-derived cancer or a parafollicular cell, in other words, papillary, follicular, or medullary cancer, any of those. A personal history of cancer is pertinent as well for two reasons. There are cancers that metastasize to the thyroid, so renal cell carcinoma being the most common one. And then also, it appears that breast cancer and thyroid cancer co-segregate in the U.S. population. So in women who have a history of breast cancer, there's slightly higher risk of having thyroid cancer, and women who have a history of thyroid cancer are slightly higher risk of having breast cancer. So those things are all pertinent positives when I'm talking to the patient. Of course, if they say, hey, you know, we have this thing called multiple endocrine something or other in the family, everybody's got it. Yeah, definitely that's one of those things that you have to pick up on. I've listed here, and I won't read for you, but I've listed the familial syndromes that are associated with thyroid cancer. Of course, the first several of these are all the way down to here are all follicular cell-derived cancers, mostly papillaries, and then familial medullary, MEN2A and 2B are medullary cancers. If a person has a symptom due to the nodule, that raises my concern about, number one, whether or not it's cancerous, and number two, whether or not it should come out. So if you have a nodule that's so big that it's creating a big problem for you, it's probably coming out, right? Also, we worry about invasion being the reason why you're having that problem. So people have changes in their voice, difficulty swallowing, difficulty breathing, pain, disfigurement, disability, etc. from a thyroid mass. That's probably coming out. Symptomatic, in other words, compressive nodules should be removed. Does anybody know what thyroid cancer actually causes painful masses in the neck? Nobody? Usually medullary is what I'm looking for on this one. Anaplastic, that's not usually their complaint, although they can have pain, particularly with swallowing. But medullary can actually cause painful nodal metastases and painful primary tumors. Very unusual for a malignancy to be painful. So symptoms that are of concern for cancer, rapid growth, invasion can cause changes in voice and difficulty swallowing. New nodules that are found in children or in older adults are also higher probability of being cancer than nodules found in people who are in their 40s and 50s. Also, solitary nodules in males are felt to be slightly higher risk of cancer. This is just a data slide from a recent publication showing what is the prevalence of cancer if you look at all new nodules found in younger people, like less than 20, versus older people, like greater than 80. And you can see that a new nodule in somebody who's maybe in their late teens, that's probably 20% risk that that's a cancer. Likewise, somebody who's an octogenarian, brand new nodule, once again, about 20% risk of cancer. For everybody else, somewhere in the middle, it's about 5 or 10% risk of cancer for most people in the U.S. population. On physical exam, I'm looking for hard, fixed nodules that are immobile, do not, normally nodules are not affixed to the overlying strap muscles or skin or underlying trachea. If you detect that, that's cancer until proven otherwise. Also, cervical lymphadenopathy that is ipsilateral to a thyroid mass. Other side's fine. The side with the thyroid nodule has a lot of lymph nodes, cancer until proven otherwise. Also, nodules that are greater than 4 centimeters get my attention. I ask myself, why did they get that big? You know, how much bigger are they going to get? How are we going to make sure that this isn't a cancer by a simple needle biopsy? Those are questions that are unanswered and, generally speaking, lead towards an operation. Blood tests that you want to get done for all these thyroid nodule patients are going to be a TSH. Okay, that is the one test that's important in determining the risk of thyroid cancer. Now, I used to go around giving talks and saying, TSH has nothing to do with it. Your thyroid function means nothing. Most people with thyroid cancer are euthyroid. They don't have hypothyroidism or hyperthyroidism. They're just euthyroid. And I used to say it has nothing to do with it. Well, the fact is that several studies have demonstrated that TSH is an independent predictor of malignancy in the U.S. population. So this is based on NHANES 3 data. If you look at the U.S. population, you group them by low, normal, or high TSH, what you find is that more cancers are found in the group with a high TSH, and less cancers are found in the group with a low TSH. Perhaps most interesting from a graph like this is the fact that if you just look at those people in the normal TSH range, as your TSH rises, the probability of finding cancer in that group goes up in kind of a stepwise linear fashion. So it's kind of makes sense now that we know that it exists, because we know that TSH is trophic to thyroid cells and differentiated thyroid cancer cells, so it kind of makes sense. There's a lot of TSH in your system. It's going to stimulate things. At least that's my teleologic argument for it. High TSH, it increases your suspicion that the person is having a cancer. The imaging that you get for thyroid nodules, you want to pick the right imaging modality, and in my opinion, ultrasound is an extension of the physical exam. It's kind of like having X-ray vision. It allows you to see exactly what is going on. It's more accurate and more specific than a CAT scan, an MRI, or a PET scan, and ultrasound is really the indispensable modality. It's the most sensitive technique. We can see things that are about a millimeter in size if we want to. It's inexpensive, especially compared to the other modalities. It's non-invasive, painless. There's no radiation. You can do it on children, on pregnant women. You can do it in your office. You can do it in the OR. It differentiates very easily things that are solid or cystic. It gives you great information on size, location, number of lesions, helps you out planning an operation. And there's also a number of sonographic features that are felt to be either more or less predictive of cancer. And once we understand those, then we can kind of pick and choose the thyroid nodules that we think we're more worried about. So here's an image from my office, actually, of a person with a biopsy-proven papillary thyroid cancer, it turned out, and it has a number of suspicious sonographic features. Hypoechogenicity means that the color of the thyroid nodule on ultrasound is darker than the surrounding thyroid parenchyma. The little white dots that you see here, if I can get the mouse to work, there it is right there. So these little white dots right here, right here, right here. When you see white dots without posterior acoustic shadowing, without reverberation artifact, that is a microcalcifications, and microcalcifications are concerning for both papillary cancer and medullary cancer. Irregular and infiltrative margins are one of the more strongly predictive findings if you're looking for cancer. If you think about it, as the thyroid mass grows within the parenchyma of the thyroid, it's kind of pushing the normal parenchyma away and creating like a halo of compressed normal thyroid tissue. And you see this halo usually as a hypoechoic ring all the way around the thyroid nodule. And if the nodule is malignant and becomes infiltrative into the parenchyma, you get a broken halo. You get a margin that is no longer sharply defined and becomes infiltrative. So we see those things, and that makes us think of malignancy. Also, borrowed from the breast literature, masses that are taller than they are wide in the anterior-posterior dimension are also concerning for malignancy. That's not the way that most benign thyroid nodules would grow. On the other hand, there are these features that are very consistent with benign thyroid nodules, like pure cysts or simple cysts. They're almost never cancer, extremely rare that those are cancers. There are cystic papillary cancers out there, but usually you're going to see some type of mural component. A pure cyst has no mural component. Also, there's a feature called the spongiform appearance, which means that, frankly, it looks like a sponge. And that's basically the appearance of it. And that has also a low probability of being cancer. So either of those would be good things to find. Also, if you think about it, I'm not going to necessarily need to biopsy a pure, simple cyst, almost regardless of its size, unless the patient has a compressive symptom, in order to try to determine if it's cancer or not. We know that the probability of cancer in a pure cyst is so low, so we can pick and choose these nodules based on their appearance and decide which ones need to be biopsied. Likewise, we use the same type of information to select lymph nodes for biopsy, or at least to understand whether or not the person may have a risk of a metastatic disease. So normal lymph nodes in the neck are flattened, elongated, and relatively small in size. Lymph nodes that have thyroid cancer in them, in particular, are large and round. They're more circular instead of more flattened and elongated. They're hypoechoic. They're usually hypervascular on power Doppler. Each lymph node has a hilus that has an artery, a vein, and a lymphatic that goes into it. And you can see this on ultrasound. In normal lymph nodes, you see a little white line right down the middle of it. It's called a fatty hilus. When your lymph node gets clogged up with cancer, you can't see that anymore. So when you lose the fatty hilus, that's bad. Also, remember these findings like microcalcifications. That should not be present in a normal lymph node. A lymph node that has a well-differentiated cancer in it starts to look exactly like the primary tumor. So you see microcalcifications, for example. If you see that, that's bad. Also, lymph nodes are almost never cystic. There are very few things that would cause cystification of a lymph node. On the top of that list is metastatic papillary thyroid cancer. Of course, if a lymph node has a necrotic mass, a necrotic malignancy in it, it can look cystic. Tuberculosis can look cystic. There's a couple of things, but 9 out of 10 of the things on that list are metastatic thyroid cancer. So if you see a cystic lymph node, that's bad. Also, differentiated thyroid cancers make a protein called thyroglobulin, and if you have metastatic cancer, metastatic thyroid cancer in a lymph node in your neck, if you aspirate that, you can aspirate it not only for cytology, to look at the cells, but you can also assay thyroglobulin within that. There should never be thyroglobulin in a benign lymph node. So all of those things can be used to determine whether or not the person has a metastatic malignancy in the lateral neck. Now, when I was in medical school, this is the way that we did prognostication for thyroid nodules. We sent them for a nuclear medicine study, and we looked for cold nodules. We took out all the cold ones. And if they were hot, we gave them all radioactive iodine. But where I went to medical school, they didn't just have cold and hot. They had warm. And it was like, well, what the heck is warm? It's supposed to be cold or hot, and we got warm, and we didn't know what to do with that. Ultimately, what we found is that the majority of cold nodules are actually benign. And, for example, the pure cyst that I was describing a moment ago, that's going to be cold, okay, and that's never cancer. So this scintigraphy study kind of has lost its luster. It's no longer the study that we would use to try to prognosticate about the nature of thyroid nodules. It still has a role in all of the guidelines. If you're trying to identify an autonomous nodule, a person who has a hot nodule that could be treated with radioiodine, yes, we can still use this. Generally speaking, what's done is they check a TSH first. If the TSH is low, if the patient's hyperthyroid, then we can move them into that pathway where they get a radioiodine scan, and we're looking for this hot nodule. Incidentally, by the way, this is not a hot nodule, this is a warm nodule because the rest of the thyroid gland is not suppressed. So this person may or may not be a good candidate for radioactive iodine. PET scans, a lot of people ask, well, why don't we just do a PET scan? My patients want to do that all the time. And PET scanning is not so good for ruling in or ruling out cancer. The reason for that is that most thyroid cancers are well-differentiated cancers, and they don't eat sugar, they eat iodine. So if we give them a radioactive sugar and scan their body, we don't necessarily see it in their thyroid gland. So they could have a well-differentiated malignancy in their thyroid. It doesn't show up on the PET at all. However, if you take the converse, if you have somebody who has, I don't know, melanoma or lung cancer or something like that, they're getting a PET scan, and you see a bright focus in their thyroid gland, not a diffuse amount of uptake, but a single focus in their thyroid gland that's PET positive, the probability that that's a thyroid cancer is about 35%. So it's a pretty significant risk factor if you have a focal area of PET uptake in one of the lobes of your thyroid gland. Now, poorly differentiated thyroid cancers are also can be used. You can use PET scan to detect those. These are the radioiodine negative, thyroglobulin positive, or poorly differentiated thyroid cancers that some patients have. But it's not, in general, a good test for just routine use for differentiating benign and malignant. Okay. What test has the highest positive predictive value for finding cancer in the thyroid gland? It's the fine needle aspiration biopsy. Here's a picture of me doing a biopsy in my clinic. As you can see, I don't believe in wearing gloves or using any kind of sterility at all. I'm married also, as you can tell here. And I like to use these giant guns. Now, I used to use these, kind of funny. I haven't used one of these in 12 years probably because I find people really freak out. But what this is this is the way I was taught to do biopsy when I was a resident, and it's called palpation guidance. You take two fingers and you stabilize the nodule. And you take a needle, and based on feel, you get the needle into the nodule. You oscillate the needle back and forth, and you make a slide out of it. It is still okay to do that. It's totally okay to do that. When the people who write the guidelines get together and decide about these things, they decide that palpation is still a way to make sure that we're not withholding care from people. So if you do not have an ultrasound in your office, for example, and you practice in a place where the nearest ultrasound is far away, you can still make a diagnosis of a thyroid mass or a lymph node or something like that by using this technique. So it is still okay to do. I think most people are using ultrasound guidance now to target their needle. You can see this is a really nice picture of a needle just sitting right in the center of the thyroid nodule. You know that the cells that you retrieve from that needle are representative of the target lesion that you're concerned about, and that you don't have the needle in the carotid or the IJ or somewhere else. I can tell you probably 4 times a year people are come to see me with their slides, and the slides are read out as ciliated columnar epithelium. And you know that doesn't exist in the thyroid gland. So I think that if they had ultrasound-guided biopsy, that probably would never happen. We wouldn't have the needle in the center of the trachea. And I usually say, did you cough a lot? Is it like really? Anyway. So ultrasound guidance probably improves accuracy, but is not essentially necessary according to guidelines. Okay? Fine needle aspiration biopsy can be used for palpable nodules, dominant nodules, incidentalomas, enlarging nodules, symptomatic cysts, basically anything you can think of, including the lymph nodes as I discussed earlier. A few years back, 2007, there was a State of the Science conference convened in Bethesda, Maryland at the NIH, where they got radiologists and pathologists and surgeons and endocrinologists together, and they decided upon a standard convention for how we would describe thyroid nodule FNAs. And when I was in medical school, it went like this: benign, malignant, inadequate, indeterminate, right? And so we operate on the malignant and indeterminates. Everybody else we probably watched. So it's really not that different now. They've just taken the indeterminate category and blown it up into 3 new categories. So the indeterminate category is blown up into 3 categories, ranking from lowest to highest risk of malignancy, and they go like this: atypia of undetermined significance, also known in some places as FLUS+, AUS, or rule out neoplasm. What that means is that there's either real, true cytologic atypia here and there, or it means it's a compromised slide. There's something about it, it's got some artifact on it or something like that. Generally speaking, this carries a risk of 10%, 15% at the most risk of cancer. It's supposed to carry that level of risk, and the guideline recommendations are to repeat the biopsy. Neoplasm is the next category, and this is what we used to think all indeterminates were. If it was indeterminate, it meant it was neoplastic. We can't tell if it's benign or malignant. We've got to take it out. This is the same kind of concept. What they're saying is this is either an adenoma or a carcinoma. Either way, we know it's a tumor. We just can't tell you which one it is. So this is Hürthle cell carcinoma. This is follicular carcinoma, and the respective adenoma varieties of those two types of tumors. Suspicious for malignancy is the last one, has the highest risk of cancer. It's probably at least 2/3 to 3/4 of these should be cancers. And what these are, almost all papillary cancers, but for whatever reason, they don't completely convince the cytopathologist that what they're looking at is cancer, and so they back off a little bit. Maybe it's a bad Hashimoto's gland. Has a lot of the overlap, a lot of similar features, has grooves, has some inclusions, but maybe it is and maybe it isn't cancer. If you get one of these, generally speaking, they're treated with surgery. Everything else is the same, okay? FNA is pretty good at telling you about these types of cancers: papillary, medullary, anaplastic, and metastatic cancer to the thyroid. It doesn't kind of come out perfectly, though. So for anaplastic cancer and a poorly differentiated met to the thyroid, in both cases, your cytopathologists say there's something weird going on. There's some bad stuff happening here. I can't tell you if it's a primary thyroid tumor, if it's something else, but either way, it looks very, very bizarre. So whether they have one or the other, you'll get a cancer reading. You just won't know necessarily what kind of cancer. Papillary should be very easy to detect. You can see the sensitivity and specificities up there. And medullaries are like that also. They have intranuclear features, papillaries and medullaries, intranuclear features that tell the pathologist that's what's going on. When does the FNA let you down? As I mentioned before, follicular and Hürthle cell carcinomas look just like follicular and Hürthle cell adenomas. So those things they still can't figure out. Some medullaries will fool them. You're looking for salt and pepper chromatin, essentially. So sometimes it doesn't quite look clear to them. Also, follicular variant of papillary can be very difficult for them to find because it may lack some of those architectural features. Hashimoto's thyroiditis shares a lot of intranuclear features with papillary cancer. There's this thing called the hyalinizing trabecular adenoma, which is a benign tumor that looks just like papillary on FNA and on frozen section. But after you take out the thyroid for a biopsy-proven papillary, they call you and say, "Good news, Dr. Sturgeon. That wasn't a cancer after all. Isn't that great?" Yeah, that's great. I have to call my lawyer now and let him know that we took out this thyroid gland for a benign thing. Actually, it's quite rare, so I see them maybe once a year at the most. Highly vascular tumors can give you just blood. You do the biopsy over and over again, you get blood, 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 blood. Those things are very difficult to nail down. Actually, tumors that yield blood only on repeated biopsies have a little higher risk of being cancer. They're probably tumors. Previously radiated glands have radiation-induced thyroiditis, so they look weird. They look like papillaries sometimes. And if you take all this stuff together, up to 1/3, maybe 30%. So 30% of all biopsies are going to have some type of indeterminate feature. So if you decide you're going to biopsy any nodule, just think of it like that. 1 out of 3 chance that we're going to find something that's going to be confusing, it's going to be unclear, it's going to be indeterminate in some way. I'm going to have to deal with that. You should biopsy those nodules that have the highest probability of being a meaningful cancer, right? So that means do not biopsy a 4-millimeter nodule, even if your radiologist thinks you should, okay? Almost all of the guidelines kind of set some type of threshold, and they say, you know, we probably shouldn't be biopsying those nodules smaller than about 10 millimeters. In fact, the ATA even says maybe 1.5 centimeters where we ought to set that threshold. Suspicious appearing nodules clearly are the ones that you would pick over those that are not so suspicious. Nodules that are associated with ipsilateral cervical lymphadenopathy, as I mentioned before, also nodules that are rapidly growing, that are found in the very young or very old, nodules that are solitary. Why does that person have a beautiful thyroid and one big nodule coming out of it? That worries me, right? That sounds like neoplasia. People who have nodules in a high TSH or maybe a high normal TSH and PET-positive nodules. All of these would increase the probability that you're going to find something meaningful. Okay. Here's where it gets controversial. So you get an FNA back, you got to decide what to do. All right, and there's guidelines to support all these things. Inadequate means repeat it. If you didn't have on-site cytopathology the first time, get it for the second time, or send it to somebody who can do a bigger biopsy, like a core, whatever it is. You're going to repeat it, try to do it better the next time. Oh boy. Benign nodules, generally speaking, we're not taking out. They are followed. We don't say goodbye to people who have benign nodules. Generally speaking, what we want to do is make sure that we don't miss something. So you're going to set up a follow-up for them. Usually we'll do an ultrasound in about 1 year to evaluate for stability of the nodule. And in other words, it's not starting to look different or get larger. And also, if there's a greater than 50% volume growth in a followed-up nodule, we usually repeat the biopsy. Comes back malignant, they're going to have surgery. We'll get into that more. Biopsies that are as neoplastic or suspicious usually get surgery, and we can get into that in a minute. And then atypia of undetermined significance category, or the FLUS category, that's where there's a lot of controversy, and there are at least 3 proprietary tests around the market right now trying to get you to sort those patients out through either a gene expression classifier or a DNA molecular test to try to figure out if they ought to be watched or taken to surgery. Let's go through a couple questions. Let me see if I can talk more about that if we have time. A 48-year-old woman has a right thyroid lobectomy for a 2.5 centimeter follicular neoplasm. Final path, it's a real cancer, 2.5 centimeter follicular carcinoma with both capsular and vascular invasion. It has access to the bloodstream, right? 3 lymph nodes are negative. What's the next step in management? Who wants to volunteer? Okay, so while I'm reading my text I just got, it's about a patient with a PET positive thyroid nodule, believe it or not. All right, so should the guy get radioactive iodine? No, right? Because you still have half your thyroid in, you can't do that. TSH suppression with levothyroxine. You could argue it's not that big of a cancer, but this one has access to the bloodstream, so I probably wouldn't. Completion thyroidectomy? That's what I think. Check a TG as baseline. Here's the problem with that. TG is really nonspecific. So the amount of thyroid globulin you have in your body is related to how much thyroid tissue is in your body, what the status is of the TSH receptor, and maybe how traumatized that thyroid tissue is. So if I just started banging on it in the operating room, if I did something destructive to it, if you had thyroiditis, a viral infection, if you had Graves' disease, your TG all goes up. Okay, so it's kind of nonspecific. It doesn't help you that much. And thyrogen scan, I just made that up. All right, so I think the right answer here is completion thyroidectomy. 45-year-old male has hoarseness and a 5 centimeter fixed painless mass in the right thyroid lobe. Laryngoscopy shows a paralyzed right vocal cord. FNA of the mass is medullary, so he's in trouble, right? Ultrasound shows enlarged, rounded, hypervascular lymph nodes in the lateral neck on the same side. Which of the following is the most appropriate treatment for this guy? Do you guys have little clickers? You do? Oh, okay, all right. All right, so I'll walk through these. 22 people have responded. Great. So neoadjuvant chemoradiotherapy followed by total thyroidectomy. Doesn't sound right to me. That would be the treatment maybe for someone who had anaplastic cancer. Anaplastic, we generally try to get them into neoadjuvant chemoradiotherapy to try to make it resectable. Not for medullary, however. Right thyroid lobectomy, resection of the right recurrent nerve, and nerve reconstruction. It doesn't sound too bad, but for a person who has metastatic medullary thyroid cancer, the recommendation is going to be a total thyroidectomy, not a right thyroid lobectomy. If the nerve is out, and it's out because the cancer has invaded it, yeah, I cut that nerve. If it means that, if you think about it, as the surgeon for medullary cancer, it's the surgical treatment that gives that patient the best possibility of beating the cancer. So you're not going to leave part of the cancer in there that's around a nerve that's dead. You're going to resect all of that en bloc, including the nerve that's been encased. It's not going to come back after you lift the cancer off of it or something like that. That nerve is gone. Total thyroidectomy with a right recurrent nerve resection and a right modified radical neck dissection is the correct answer. A subtotal thyroidectomy is not considered a proper cancer operation for any thyroid cancer. A right radical neck dissection means that you're taking out the SCM, the 11th nerve, and the internal jugular vein, and that is not what we do for thyroid cancer. Absolutely, we take out the jugular vein when it's invaded, right? And if you had some other structure that was invaded, you might take that out as well. But in general, we do not routinely do a radical neck on these patients. A modified radical, and all you need to do is remove one of those things. It's still modified. If I were giving ENT boards, and I don't do that, but if I were and someone said, the nerve's out, I do a big whack, and I'm going to put a surgical airway in, I would say, okay. I mean, I never think that's wrong. If you have done a central neck around the only functioning nerve they had, a huge operation, and you said, I'm going to put in an airway, I think that's probably okay. But the rest of the stuff in this question I think is wrong. Near total thyroidectomy, parathyroidectomy with forearm autograft and selective dissection, wrong for a couple reasons. We didn't talk about having hyperparathyroidism for this patient. And a selective dissection means no plucking, okay, or cherry picking. And that is never the correct answer for thyroid cancer. For any thyroid cancer, we're going to do a formal compartmental clearance, a formal nodal basin clearance. We're not going to just pick out the nodes that look positive to us in the neck compartment, regardless of where that compartment is. So that's why that is wrong. Okay, into the controversy. So what operation do you recommend for thyroid cancer? That's where we're in the controversy right now in endocrine surgery. So papillary thyroid cancers that are larger than 4 centimeters, there is agreement that we should be doing a total thyroidectomy for them. Or if they have positive nodes, clinically positive nodes, or if the primary tumor is a T3 or a T4 tumor, regardless of size. Okay, so T4 meaning that it's invading into the airway or the recurrent nerve or the esophagus or something like that. T3 if it's extending into the perithyroidal soft tissues. Either one of those, regardless of size of tumor, or if the nodes are positive, we should be probably doing a total thyroidectomy in all those patients. Papillary thyroid cancers that are less than a centimeter have been proven over and over and over again. Doesn't make a difference if you do a lobectomy or a total for those unifocal tiny cancers that have not spread anywhere. Papillary cancer 1 to 4 centimeters, that's where there's been a recent change. So at this time, the ATA at least says that you can do a lobe or a total for these patients, and that they would do probably equally well in terms of survival if you did a lobe or a total. There's one paper that suggests that recurrence, there's probably more than one contemporary paper that suggests that recurrence would be better for a total thyroidectomy, but the most recent very large database study just looked at survival and said survival is no difference between lobe and total, right? So that's why right now they say if you're between 1 and 4 centimeters in terms of size, and you don't have a T3 or a T4, and you don't have metastatic nodes, you could choose a lobe or a total for that patient, and either would be correct. Also, patient preference should be one of the strong things that also drives this. Patients should be informed about what's going on, what the risks are, and they should be part of that decision process. People with follicular neoplasms or Hürthle cell neoplasms are generally treated with a lobectomy, and then if a total thyroidectomy were warranted, you would do a completion. Minimally invasive follicular and Hürthle cell carcinomas are generally treated with a lobectomy. You see the trend. We're doing more lobectomies now. Follicular and Hürthle cell carcinomas, especially those that have access to the bloodstream, are going to be probably treated with totals if we had our choice. Medullary cancer, still a total, okay, unless we're talking about a 5-millimeter medullary found incidentally on a path report. You know it's medullary cancer beforehand, they're going to get a total thyroidectomy and a bilateral central neck dissection. And many of those patients are going to have positive nodes in their lateral neck and get an ipsilateral modified radical too. Anaplastic cancer, your job as a surgeon is to protect their airway. Resect it if it's resectable, otherwise protect the airway, get them into neoadjuvant chemoradiotherapy. I saw 3 anaplastics in the last 12 months. 1 of them I got to surgery. And that's generally the ratio usually. It's maybe 1 out of every 3 or 4 or 5 anaplastics I see will ever even go to the operating room. They generally speaking get neoadjuvant and then go into hospice because they all have unresectable disease. What are the goals as a surgeon for thyroid cancer? Minimize the morbidities, okay, so don't do unnecessary surgery, don't cut things you shouldn't cut. Permit accurate staging, meaning that when you are evaluating a patient, think about nodal metastases, because nodal metastases, when present, upstage the patient, especially when they're clinically relevant. So we're not going to do lobectomies or total thyroidectomies without considering the possibility of nodal disease. Facilitate postoperative treatment means don't leave a big chunk of thyroid in if you don't have to. And the same thing with permitting accurate long-term surveillance and removing the primary tumor and any extrathyroidal disease. So those are the stated goals of surgery for thyroid cancer. Let's think about the path report when it comes back after you've done the operation. These are the possible pathologic findings. There's papillary, follicular, medullary, anaplastic, as you know, and there's also a number of sub-classifications for papillary cancer. There's the tall cell variety, which is probably the more well-known variety, which is more aggressive. Columnar cell, which over the years people have said is or isn't more aggressive. Follicular variant, 20 years ago, was thought to be more aggressive. Now it's thought to be about the same or maybe better. Follicular carcinoma also is described as Hürthle cell cancer sometimes, and then the poorly differentiated version is insular carcinoma. So these are the possible path reports that you might get. The complications you must discuss with the patients before surgery: temporary or permanent nerve injury of either the recurrent nerve or the superior laryngeal, temporary or permanent hypopara. Look at the numbers, about 20% for temporary problems with any of those nerves or with a parathyroid. It's pretty high, pretty significant. You need to tell people that this is what could happen. And the permanent nerve injury is probably around 2% in expert hands. You take, a bunch of expert surgeons, you have them do thousands of operations, 2%. For the person who doesn't do a lot of thyroid surgery, it's known to be much higher. So these are the expert numbers. Hematoma, wound infection, seroma, all quite rare that they would cause any kind of significant issue. Let's talk about the cool stuff. The relationship between the nerve and the inferior thyroid artery, I think, is kind of cool. On the left and right, it's totally different. So on the left, the nerve kind of runs north and south, straight up and down in the tracheoesophageal groove. On the right side, it takes a more oblique course. It turns more lateral as it goes inferior because it's got a loop around the subclavian on the right, it's around the aorta on the left. So on the left side, the nerve typically, about 50% of the time, runs deep or posterior to the branches of the inferior thyroid artery. About 1/3 of the time, it interdigitates. So branches of the recurrent nerve and branches of the artery are kind of crisscrossing. That's kind of a high-risk situation. And then about 15% of the time, the nerve runs anterior to the branches of the inferior thyroid artery. Both of these two latter situations are kind of high risk in my mind. And when you are rotating the thyroid gland towards you to dissect in the TE groove, you're pulling the nerve towards you in both of those situations. The nerve is coming up closer to your field than you would expect because it's being brought there by the artery that you're pulling along. And for this reason, you don't know if these patients have it anterior, posterior, some of each. You're going to divide all the branches of the inferior thyroid artery really high on the thyroid, right at the tertiary levels, in order to avoid potentially injuring a nerve that you haven't seen the full course of yet. On the right side, look at this. About 50% of patients have this treacherous interdigitation. About a quarter, the nerve is behind. About a quarter, the nerve is ahead. So it's different depending on the side. But in both cases, if you're dissecting right on the thyroid lobe and taking those individual branches of the inferior thyroid artery, you're going to do two things. You're going to stay far away from the nerve, and you're also going to have the greatest probability of preserving the blood supply to the parathyroid glands. Which brings me to the next topic. How do you avoid hypoparathyroidism? You do so by dissecting right on the surface of the thyroid gland, actually looking for the parathyroid tissue and try to identify it and preserve it on a blood vessel. Ligate the inferior thyroid artery high on its tertiary branches, I just mentioned. And then if you have evidence, demonstrable evidence that you have devascularized a gland, then it should be immediately autotransplanted. So if you rip off a parathyroid gland, don't just sit there and stare at it. Chop it up and put it back into the patient. Generally, we put it in the ipsilateral sternocleidomastoid where I practice. I know people also put it in other locations. Always inspect a thyroid before you send it off to pathology so that you're not sending a bunch of parathyroid glands on it. We don't need them to know what a parathyroid looks like. We just, look at it. If it's on the gland, take it off and put it back in. And this is my favorite thing to avoid. I can tell you a story because I'm a few minutes ahead. When I was a fellow, we used coronary suckers. Now, you know what the tip of the coronary sucker looks like? It's small. It's really tiny. And my boss said, don't get that sucker near the parathyroid gland. And I thought to myself for a second, there's no way that this parathyroid is going to go into that sucker. And about 2 seconds later, it was like, right into the sucker, and it was in the wall suction, like in that canister, and there's no way that you're going to retrieve that thing and stick it back in the patient. It's not even remotely sterile. And I was in super big trouble for that. But I have definitely done it myself. I've had residents do it to me. So just keep the suction way, way far away from the parathyroid. So it'll go right in it. Okay, so that I think ends our thyroid surgery block. I'll take a couple questions for about 5 minutes. Yes, sir.
What about the use of the new neural recognizing device?
The neural recognizing device, also known as nerve monitoring. That's what you mean? So to check. So that's a great question. So I've actually conducted a survey on that, and a lot of people are using nerve monitoring. There isn't a you don't have to, okay? So there isn't like a guideline or a rule that says you must use nerve monitoring. The gold standard is visual identification of the recurrent nerves during an operation. So if you had a nerve injury and you were sued for it, the belief is that you could point to guidelines and say the gold standard is visual identification, right? Now there's a lot of money behind this, so there's a lot of people that want you to think that using a device will protect you from hurting the nerve. Frankly, it's your skill level, how many times you've done that operation, how careful you are, and whether or not you visually identify it. That's probably the critical aspect. I use nerve monitoring. Actually, when I started, I did, I don't know, my first 600 or something like that with no nerve monitoring at all, even like redo central necks. And I kind of got forced into doing nerve monitoring by my partner to have like the same, we wanted a uniform practice. And I think I would say it helps me in a small percentage of cases. And in those small percentage, there's two things about it. One is I think, oh, it really saved my butt just now. And the second thing about it is I can't predict which cases those are. Like it's not like some of them are no-brainers. Redo, third time, parathyroid, and a radiated neck or something. I'm going to need that, right? But sometimes it's not, and you don't know when you're going to encounter something bizarre that it would be helpful to know. So I don't think there's anything wrong with it, but also if I was asked to like testify in a court of law, I would say it's not the standard of care. The gold standard is visual identification. Yeah.
When you've removed a cancer that was, a couple of centimeters, and you're in that 1 to 4 centimeter range where you could either take the rest of the thyroid or not. When you talk about the use of radioactive iodine, my understanding is that the use of radioiodine in that situation, if you don't do a completion thyroidectomy, is not really going to solve your problem. It's not going to add to the treatment of the patient, and will still not allow you to follow them with thyroglobulin down the road.
Let me repeat your question for everybody else. So what he said is you've done a thyroid lobectomy for a cancer, and I'm paraphrasing you, I don't believe there's any role for radioactive iodine in that patient. Correct?
Correct.
That is correct. So if you have half of your thyroid in place, administering radioactive iodine to that patient isn't going to do anything. The normal thyroid cells that are not cancerous have an extremely high affinity for iodine. The cell surface is covered with NIS, and you give iodine to that person, it's going to go to those cells in abundance. Thyroid cancer is not as well differentiated as normal thyroid cells, right? So there's less of that cell surface expression, and it has a little lower affinity for iodine. So you could have metastatic thyroid cancer in your lung, and half your thyroid in place, you get a dose of radioactive iodine, almost all of it's going to go here, and almost none of it is going to go to treat cancer. So that's why we don't give radioactive iodine for people who have a lobectomy. It's not helpful. Yeah?
When and what type of node dissection do you do in thyroid cancer?
So I'm repeating your question. When and what type of node dissection do you do in thyroid cancer? I'm glad you asked that. So prior to surgery, it is recommended that everybody has a neck ultrasound to try to establish what you think the status of the nodal basins are. Neck ultrasound is really good for evaluating the lateral neck, maybe not so good for evaluating the central neck, especially in Chicago where the BMI is 40. Okay? So if you knew before surgery that you had a positive nodal basin, you would plan a formal clearance of that nodal basin. So I'll give you a few examples. You know before surgery that there's a thyroid cancer in the right lobe and there's suspicious lymph nodes in the right lateral neck. You've even biopsied one and it's cancer. That person gets a total thyroidectomy. a right modified radical neck dissection, and guess what? Almost certainly a right central neck dissection too, because it's very unlikely that that nodal basin is not contaminated. If you found in the middle of an operation that you have a nodal basin that's positive in a central compartment, that should likewise trigger a formal clearance of that central compartment. So either the preoperative or intraoperative detection of clinically positive lymph nodes triggers formal clearance of the compartment that's affected. Does that answer the question? The only other question I think would be when you do a prophylactic dissection, like there's no evidence whatsoever. That's for, so some people do it for papillary, but it is, a board's answer would be for medullary thyroid cancer. That is a standard component of the treatment. Total thyroidectomy, bilateral central neck dissection, even if the nodes look okay, right? I think that's pretty good. Any other questions? I'll take one more question if you have it. All right, let's rock on. We're going to talk about hyperparathyroidism. Set of guidelines, by the way, was just published in JAMA Surgery like this month or in August, so this is kind of pertinent. 60-year-old woman has routine blood work done by her primary care doctor. She's a calcium of 12.7. You can see the normal range right there. Her past medical history, she's got high blood pressure, depression, osteopenia. She's an otherwise healthy and physically active attorney. What's the next best test? Let's see if we can get 30 people. All right, wow, pretty good. 5 seconds. So remember, she's an attorney. That's right. You've got to do a PTH, right? So I was looking for a couple people to answer sestamebe scan. So just having a high calcium doesn't mean much. You have to establish the diagnosis of hyperparathyroidism, so you have to get a PTH that's high and a calcium that's high at the same time. What if she had metastatic cancer to her bones or something, you know? She's a lawyer. Come on. Anything could happen, right? So you have to just establish the diagnosis. Get a PTH first. 24-hour urine VMA and metanephrines, that's for pheochromocytoma. MIBG, likewise, for pheochromocytoma and bone scans, just a bunch of nonsense. All right, this is just straight out of M1 lecture. Normal situation, when calcium's high, PTH is low. When calcium is low, PTH is high, and vice versa. And hyperparathyroidism, the PTH drives the situation. The parathyroid gland makes as much PTH as it wants to, doesn't care what the calcium is, and then the calcium follows because of the effect of PTH on the skeleton. The differential diagnosis is long. It's a laundry list of stuff. And most of the reason why people might have a high calcium is primary hyperparathyroidism. It's probably 80 or 90% of people with high calcium out there. Hypercalcemia of malignancy is the other. And then there are also a bunch of rare things. So when I was in medical school, if you had PTH-RP or PTH that was high, you couldn't tell which one it was on a PTH test because it cross-reacted. So if you wanted to know if it was PTH-RP and not PTH, you had to send a special PTH-RP test. We don't have to do that anymore. So PTH, if that's what's causing your calcium to be high, and you send them off for PTH, if PTH is high, you're going to get a high PTH. And if it's PTH-RP, you're going to get a low PTH. So when you have malignancy that's driving your calcium, it's usually, number one, not a mystery. It's usually an advanced cancer. It's been there for a while. People know about it. And number two, when you check the PTH, it's going to be very, very low. All right, so hypercalcemia of malignancy should not confuse you. There is a cancer that can present as hypercalcemia and frequently does, and checking PTH is important. Anybody know? Myeloma, so multiple myeloma frequently presents as hypercalcemia. So you check a PTH in those people, it'll be low. There are, of course, tumors that make PTH-RP. There are some very rare tumors that make PTH, pure PTH, that could really mess you up. The one I think that will clinically mimic hyperparathyroidism and fool us the most, although fortunately it's also very rare, is benign familial hypocalciuric hypercalcemia. That's a autosomally dominant inherited mutation, the calcium sensing receptor. These patients have had high calcium since they were 10 years old. 50% of their relatives have it on one side, and if you check their urine calcium, it's quite low. The problem is they don't pee out calcium very well, so the calcium is high in their bloodstream. So the way we discriminate hyperparathyroidism from BFHH is we check a 24-hour urine calcium, and generally speaking, BFHH people should have a less than 100 milligram per day clearance or excretion, of calcium. There's also a genetic test, but insurance doesn't like to pay for it because measuring calcium in the urine is cheaper. Hyperparathyroidism is pretty common, actually, and it's probably 1 in 500 postmenopausal women and about 1 in 2,000 men in the same age group. The peak incidence in the textbook says 50 to 60. Recent study out of Kaiser, Southern California, shows that the incidence of hypercalcemia, or the prevalence, I should say, rises with every decade. So if you take a cross-section of 50, 60, 70, 80, 90-year-olds in the Kaiser system, you see more and more hyperpara with each 10 years. So the incidence starts to become apparent at 50 and 60. Women are more commonly affected than men, about 3 to 1, and most patients are thought to be, quote, asymptomatic, which means actually that they were detected on a routine blood test and not because they went into their doctor's office complaining of some complaint that then yielded a diagnosis of hyperparathyroidism. If you ask the right questions, if you look at survey studies, what you'll find is that most patients, like 95% of hyperpara patients, have a symptom. We're just not asking questions very well, and we start calling people asymptomatic when they're really not. The medical students still have to memorize this mnemonic: stones, bones, groans, moans, and overtones. It's kind of fun to do, and this is a picture of Charles Martel, who, if I had more time, I would tell you stories about, maybe at the end of the day, who is the first person to have a, quote, successful parathyroidectomy on U.S. soil. And this picture serves to remind us about some of the more profound symptoms of hyperparathyroidism. You can see him here before he was diagnosed in 1918, and then here after he had the disease in 1926. He's lost about 7 inches of height, almost all from compression fractures. He had lots of kidney stones. He had terrible bone disease. He had kidney disease. So he had the whole 9 yards. And this was kind of the classic way that it was presented before about 1969, when it started to be in the routine autoanalyzer for Chemistry 7. The symptoms are a little bit more complicated than stones, bones, groans, moans, and overtones. They can be divided into more scientific groups where you have musculoskeletal manifestations, renal manifestations, neuropsych, GI, cardiovascular, and other miscellaneous things. So it's actually pretty comprehensive now to try to ask people about all of their various things. There's a lot of interesting stuff if you start diving into this. In Denmark, they have shown all-cause mortality higher in patients who never have their calcium treated. There's more MIs, there's more strokes. Arterial stiffness is worse. There's LVH. LVH will actually get better after you treat hyperparathyroidism. There's a lot of poorly understood and very fascinating symptoms associated with hyperpara, more than just these neuropsych things that people know about. The lab findings: high calcium, high PTH, and a low 24-hour urine calcium clearance. That's your textbook definition of hyperparathyroidism. Now, I should mention, there's also something called normocalcemic hyperparathyroidism. That's when your calcium is at the upper end of normal, your PTH is high. All right? Doesn't make sense. When your calcium is at the upper end of normal, your PTH ought to be at the lower end of normal, should be very low. And this is a situation where it's kind of out of whack. And there's also something called hormonal hyperparathyroidism, just to confuse everybody. And that's when your calcium is high and your PTH is not high, but it's inappropriately high. It's like at the upper end of the normal range for PTH. That's also a situation where it's inappropriate. It should not be like that. And those people are all thought to be on the spectrum of hyperparathyroidism, but they have not quite reached the classic textbook appearance where everything is elevated. And then there's people that are upper end of normal calcium, upper end of normal PTH. What do we do with that? So there's a lot of work to be done still with hyperpara. The cause of disease is sporadic in most cases, and solitary parathyroidinomas are thought to be about 80% of the patients. Depends on what city you live in. In Cleveland, it's like 70%. In Chicago, it's more like 85%. So it depends on the studies that have been done and how well they evaluated all the parathyroid glands in those studies. But still, solitary adenoma is the majority of the cases. Multi-gland disease represents the rest of them. And most of those are probably all 4 glands hyperplastic. Occasionally there's double adenoma where 2 of them are good, 2 are bad. And then about 1%-ish of patients with hyperparathyroidism have it because of parathyroid carcinoma. There's also the acquired or inherited varieties of hyperparathyroidism that come with neck radiation, as I described about 30 minutes ago. Lithium use for affective disorder, so lithium definitely drives hyperparathyroidism. MEN1 and MEN2A patients have hyperparathyroidism. There's a entity called familial isolated hyperparathyroidism where it's probably an MEN1 cohort where they just get hyperpara and they don't get anything else. And there's something called hyperparathyroidism jaw tumor syndrome, HPTJT, where they get hyperparathyroidism and they get jaw tumors. And interestingly, about 50% of the parathyroid tumors in these cohorts are cancers. So parathyroid cancer is very common. In terms of indication for surgery, any patient with symptomatic hyperparathyroidism or marked hypercalcemia should be offered an operation. There is no debate. The surgeons agree, the endocrinologists agree, the internists agree, everybody agrees. People who are symptomatic, people who have hypercalcemia that's marked, people who are willing surgical candidates, they should all be sent for surgery. There have been 4 guidelines in recent history for how to manage patients who are asymptomatic. So whenever you see there's been 4 guidelines, workshops convened, you know that there's no consensus in those. They keep changing and moving around. I have put in the red box here the most recent ones that were published in 2014, actually, from a conference done in 2013. And they go like this. And these are really testable for the residents and medical students, by the way. So all you need is one of these things and hyperparathyroidism, and you ought to have an operation. So either a calcium that's 1 milligram per deciliter above normal, osteoporosis at any site as defined by a T-score of negative 2.5 or smaller, or a fragility fracture, or a demonstrated vertebral fracture on cross-sectional imaging. So in essence, it's like end-stage disease or end organ disease on the skeleton. Okay, so if a person is hyperpara, their skeleton's totally normal, fine. But if there's evidence of osteoporosis or fracture or something like that, then those people are no longer really asymptomatic. They're having a problem. Creatinine clearance less than 60, 24-hour urine calcium greater than 400, presence of a kidney stone or history of a kidney stone. And if you're going to watch a person, you're an endocrinologist, you're going to watch them, and you say, this person doesn't have any symptoms, doesn't have any things, you're supposed to do some type of imaging study to prove that they don't have a kidney stone in there, like an ultrasound or a CT or something like that. Also, if they're younger than 50, they ought to have surgery, even if they're asymptomatic. Doesn't matter if they have any of those things. If their age is younger than 50, they ought to just have surgery. So you just need one. So why are we doing more surgery even on these asymptomatic patients? And the reason is that studies have shown that they used to think that these patients were really stable and they would just go on and everything would be fine, and that's really not the case. Especially a study that was done out of Columbia where they followed patients and did their bone densities over 8 to 10 years and started to see a sharp and significant, statistically significant, and continued decline in bone density in those patients. They had cohorts that also had higher fracture rates, and they realized, hey, these people aren't stable. We probably ought to intervene before they have fractures and before they have osteoporosis. Also, the converse was found to be true, where people who had surgery, their bone density went up, their fracture rate went down. All right, so we're doing some good for these patients if you just look at the skeleton and nothing else. Localization is a big topic of controversy. When I was a resident, this is what I heard all the time. I'd say, hey, we're going to do a CEST amoeba or anything, and my attending would say, hey, the only localization study this patient needs is to localize me. It's probably true. That's actually a quote by John Dotman, who is a radiologist at the NIH. He made his living doing CEST amoeba scans, and he firmly believed that it was really the experience of the surgeon. You couldn't make somebody into a good surgeon by showing them a positive CEST amoeba scan. Same thing's true now. I mean, that hasn't really changed. The x-rays are not going to make it a simple operation. You still have to kind of know what you're doing. We still use them, okay, so there's a lot of reasons why we should be doing localization studies on patients. There's a couple caveats to know about them. They're not for the diagnosis of hyperparathyroidism. They're not to confirm that you got the diagnosis right. The purpose of getting some type of imaging before you open somebody's neck up is for you to plan your operation, to know what you're getting into, to know what you're going to find when you open the patient up. The reason we don't do it to confirm a diagnosis or rule out a diagnosis is just too many false positives and too many false negatives. But it's very useful to know, is there a big thyroid cancer in a way? Is there some other crazy thing? Is there a big goiter? Is there something else happening here that I need to know about? Because I don't like to discover things in the middle of an operation. So there's some really germane reasons why we should be imaging patients. So ultrasound is one of the, what I think is one of the most essential imaging tools, as I told you before, for thyroid nodules. I think it's also very good for identifying location, depth, size, shape, coexistent disease if you're trying to find a parathyroid. Sestamibi is the other one that people use a lot of, and this is a functional study. So ultrasound is an anatomic study. It doesn't tell you that that's really, truly the overactive parathyroid. It tells you a lot of great anatomic information. Sestamibi has fewer limitations. It can see through bone. It can find things in ectopic locations, like down on the chest and stuff like that, but it doesn't give you great anatomy. So, for example, with the picture like this, you don't know, is that anterior mediastinum? Is that posterior mediastinum? Is that aorticopulmonary window? Where is that? I don't know. So you have a marriage, okay? You have a functional study and you have an anatomic study, and putting those two together is what a lot of people do. And there are a number of anatomic studies we can talk about, like CAT scan or MRI, okay? So there's a bunch of these things. I like ultrasound because, as I mentioned before, it gives me great information about size, depth, location, coexistence disease. About 80% of the time, I think, in the hands of a skilled ultrasonographer, about 80% of the time we'll see where it is, if it's a single adenoma case. Sestamibi scan, similar. Probably about 80% of the time we get some useful information, but it can fool you. It can give you false negatives of small glands. If you have coexistent thyroid disease, you can have a lot of false negatives and false positives. You know that thyroid cancer, well-differentiated papillary cancer, shows up on a sestamibi in a lot of patients. So you can have a thyroid cancer mass that's sestamibi positive, and you think, oh, that's where the parathyroid is. So there's a lot of these things you have to be aware of, false positives and false negatives. MRIs and CTs, I was never a big fan of it, but there is a protocol that you can use called a 3D CT or 4D CT, and what that is essentially a CT angio. So it's just a highly timed, thin cut, cross-sectional imaging of the neck area after a contrast bolus, because these parathyroid glands will hyperenhance. So that has been shown to be very useful in some settings. Especially if you work in a place where your imaging is not that great, this is much less operator dependent. You just put the patient in the scanner, you do the scan is done, you try to find the thing. I did a study about 10 years ago now where we looked at, and I usually show these slides to rooms full of endocrinologists and not surgeons, but we looked at sestamibi positive and negative patients, and we asked the question, you know, what do we find after we open the patient up? And what we found is that if the sestamibi scan was positive in a single location, we found a lot of single gland disease. And if it was negative, like you got a sestamibi on the patient to show anything, we still found a lot of single gland disease. About 75% of the time, we still found one single adenoma. And so what that tells us is that the sestamibi scan, if it's negative, doesn't mean that you got the diagnosis wrong. It doesn't mean the patient doesn't have hyperpara, doesn't need surgery. And unfortunately, this is actually the truth. This is what most of the time happens. A person never gets to you because their sestamibi was negative, and the patient was never sent to a surgeon. And that's quite unfortunate, because most of those people have single gland disease. They all really have hyperparathyroidism. And the follow-up study, we looked at what's the chance of cure. So we looked at the same 400 patients, and we asked the question, were they cured at 6 months? And looking back, what did their sestamibi initially show? So the cure rate for somebody who had a positive sestamibi was 95%, and for people who had a non-localized or a negative sestamibi, the cure rate was 97%. Those numbers are not statistically different, by the way. But the message is, if your patient has hyperpara, you got the diagnosis right. It's made by blood tests and sometimes urine tests. And it doesn't matter if those patients have a positive or negative localization study, they deserve to go see a surgeon and be offered an operation to cure their disease, because they will be cured if they get the right operation. In the operating room, a lot of people use some type of modality to try to tell them that they have removed a parathyroid or perhaps the offending parathyroid gland. The most common one used in the United States, I believe, is intraoperative PTH monitoring, where PTH is measured before a parathyroid gland is taken out and then sequentially after it's been taken out to prove you've taken out the source of the overabundant parathyroid hormone that they have. The reason it works, half-life's about 4 minutes. So the PTH will drop really fast. If you have single gland disease, 3 normal glands that are dormant, haven't been doing anything for a couple years, 1 big tumor that makes a lot of PTH, take it out. 10 minutes later, your PTH is going to be quite low. It should be definitely less than 50% of what it was before. Most people use what's called the Miami criterion, where the PTH has to drop greater than 50% at either 5 or 10 minutes after taking out the parathyroid gland from its highest baseline that you measured in the operating room. I think a lot of people combine all these things together to try to achieve the greatest cure, doing like a sestamine and ultrasound beforehand, measuring the PTH intraoperatively. There's plenty of practices in the United States where 4-gland expiration is a common practice. Just do a 4-gland expiration, everybody. That's totally fine. I have a lot of friends who do that and achieve very high cure rates. A lot of them still do ultrasounds beforehand to try to localize, understand the coexistence disease that they're getting into. I'm trying to think of a number off the top of my head, but I have many patients where they came in for hyperparathyroidism. As a process of every single patient getting an ultrasound, we detected thyroid cancer, a meaningful thyroid cancer, not a 1 millimeter thyroid cancer, but metastatic, like stage 3, stage 4 thyroid cancer. So doing an ultrasound, I think, even if you do 4-gland expiration on every single patient, is appropriate to do. Where am I at? When do localization studies fail you? They're terrible in multi-gland disease. Here's an example. MEN1 patients all have 4-gland hyperplasia. None of them have single adenoma. They all have 4-gland hyperplasia. However, they have a big gland, they have a small gland, and have 2 in the middle. Guess which one shows up on a sestamebe if you do a sestamebe on an MEN1 patient? The big one. You see, it looks like single-gland disease, but they don't have single-gland disease. They have multi-gland disease. So people with multi-gland disease, sestamebes lie to you. So if you know that based on their history, they're likely to have multi-gland disease. They have MEN1, they have MEN2, they had lithium, they had radiation, something like that. Their mom had multi-gland disease, whatever it is. Then sestamebe is fine, but these people, you have a very high probability of having multi-gland disease, and you're going to do a 4-gland expiration for them. People with coexistent thyroid disease, as I mentioned before, people with prior thyroid or parathyroid operations, people with MEN, and people with small glands. All of these will work against you to fool you when you're looking at those sestamebe scans. The consensus opinion on parathyroidectomy is that it is the most cost-effective treatment for hyperparathyroidism, regardless of whether or not the patient has any symptoms. So even in a totally asymptomatic patient, parathyroidectomy is more cost-effective than observation or drugs. It should be done by people who have done a few of these and not by complete novices. The reason for that is that the volume outcome studies have really shown a huge delta in the probability of cure. Preoperative localization is only for surgical planning and not for confirming or ruling out the diagnosis. And finally, a focused parathyroidectomy in a localized patient or 4-gland expiration, both okay. So I tell the residents if it's oral boards, either one is fine. Decide what you're going to do. You can defend either one.
If you are doing a focused exploration, you find a gland, looks like it's a nice parathyroid adenoma, you get histologic confirmation, and you don't have a rapid PTH assay in your hospital, is it acceptable to stop the operation?
Great question. Okay, so let me rephrase it. So if you do not have the ability to measure PTH in your hospital, is it okay to do a focused parathyroidectomy? That's the question? That's a tough question. So it's probably okay. The most studies, I think I didn't go through it, but on one of my slides it said double localized patients. So if you have a concordant finding on an ultrasound and a sestamebe, let's say the left lower is your offending parathyroid adenoma, and you explore the left lower and find a parathyroid adenoma, and on top of that, you look at the left upper and it's stone cold normal, the probability that there's another one on the other side, it's probably less than 5%. So do you need to explore the other side 95% of the time? You know you're not going to find anything, right? So it's a tough question. Most people will try to use that some other modality to prove that what they've taken out is the one and only cause of their trouble. But would you be performing malpractice if you did a unilateral expiration in a well-localized patient? Probably not. You haven't hurt the patient for sure.
So as far as what's considered standard of care is a rapid PTH assessment now.
No, so I think that that's a good recommendation. But so we just published these guidelines, and we stayed very, very far away from standard of care. So if you say standard of care is to use intraoperative PTH, then that would mean that if you don't have intraoperative PTH, that you're committing malpractice if you do a parathyroidectomy in your hospital. That's silly, right? So we can't do that, and that doesn't make sense, and that's not right. I think that in a situation where, as I just described, a well-localized patient, you've done a unilateral expiration, you find a normal, you find an abnormal right where everything said it was, you'll be okay doing a unilateral expiration. I don't think anyone would find fault in that. But many people do routine four-gland expiration. So I'll throw a question at you. Let's say you don't have intraoperative PTH. Well, let's say you do have intraoperative PTH. You do a four-gland expiration, find 3 normal glands, 1 abnormal gland. Do you need to check a PTH? See, I'd say no. Because then you're saying, I found 1 bad gland, and there's a 5th one, and it's a bad one too. Double adenoma. So super rare, right?
You're talking single
Right.
digit percentages.
Yeah.
Missing something.
Right.
Either way.
Either way, it's single digit. Exactly. So I think either one would be acceptable. You could say, I do 4-gland expiration on everybody. I don't check intraoperative PTH. I make sure I visualize all 4 glands. Or you could say, I take well-localized patients only and do focused expiration, and I check a PTH because I'm not going to look at the other glands. But once you start mixing and matching all those things together, then the incremental value of checking PTH starts to drop. Added value goes away. Which of the following is expected outcome from subtotal parathyroidectomy in a patient with secondary hyperpara due to renal failure? Which is an expected outcome? I have to think this over a little bit. Calcium phosphorus product goes up, phosphorus goes up, bone pain gets worse, osteitis fibrosis cystic gets better, or they get calciphylaxis. What's an expected outcome? Okay. It's almost like a double negative, the way it did it. Okay, so calcium phosphorus product goes down when you do a subtotal parathyroidectomy and renal failure. Both drop dramatically. In fact, you usually do the operation because the calcium phosphorus product is too high. Calcium's too high, phos is too high. And that's bad because they can get calciphylaxis when the calcium phosphorus product is too high. Phosphorus almost always goes down after this operation too, and you think, well, that doesn't make sense because usually phosphorus is opposite calcium, but their bones are sucking in both calcium and phosphorus, which is why they both go down. Bone pain gets better right away in these patients, and patients with brown tumors actually start to resolve those brown tumors. I had a patient with multiple brown tumors in her pelvis, essentially remodel and have a normal-looking pelvic MRI 6 months later. So you can definitely help out even those people with like see-through bones with brown tumors. Calciphylaxis is a terrible complication of renal failure and is an indication for an urgent parathyroidectomy. They don't develop calciphylaxis from their parathyroidectomy. If you think about secondary hyperpara, there's a million different definitions. So anybody who's had a gastric bypass has secondary hyperpara. Anybody with a malabsorptive GI tract condition has secondary hyperpara. What I'm talking about is specifically secondary hyperpara due to renal failure. And it is caused by hyperphosphatemia, hypocalcemia, and the fact that the kidneys are not converting 25 hydroxy vitamin D into 1, 25 OH vitamin D. Those are the 3 things that are like the perfect storm to make the parathyroid glands overactive. The indications that many of us use for surgery, we set a threshold of the calcium phosphorus product should never be above 70. Anybody who's hypercalcemic, bone pain, intractable itching, any brown tumor, tumoral calcinosis, tendon ruptures, calciphylaxis. I had a guy who was in Walmart reaching for something on the upper shelf, snapped both of his quadriceps tendons, not his patellar tendons, quadriceps tendons. That's a really brittle, fragile person. So they can get pretty significant issues. Anybody with calciphylaxis also, and their mortality rate is about 50%. They need an urgent parathyroidectomy. Tertiary hyperparathyroidism depends on who you talk to. The endocrinologist might say anybody who's on dialysis and has renal failure and gets hypercalcemic is a tertiary. In the surgical world, we usually reserve that term for people who have received a kidney transplant, but despite the normalization of the renal function, continue to have hyperparathyroidism. They have some autonomy or something like that. So that's what I'm talking about here. This PTH is not responsive to their improved renal function, their improved vitamin D level, and their lower phosphorus level. Those people, I think about, when do I operate on them? It's actually very controversial. So if you wait 2 years, so if they get a kidney transplant and you wait 2 years to do nothing, many of them will resolve. Many of them will not have hypercalcemia anymore, will not need anything. But in that intervening time, there are some people that are going to get a stone in their graft, and then they're going to reject, or they're going to have infection or something like that. We don't want that. There's some people that are going to have profound hypercalcemia, 13.5 or something. They're going to have neurocognitive changes from their hypercalcemia and neurocognitive changes from their immunosuppression drugs that they're on, and they're going to have issues. So we need to try to set some thresholds for where we're going to operate on those people. And generally people who are severely hypercalcemic, anybody who's had a stone, anybody who we think has a high risk of having a stone, people who have any kind of complication from it, and absolutely anybody who comes to see me, it's been 2 years since their transplant, and they still have hypercalcemia, for sure they're getting an operation. Surgical issues, these are the fun things. I have my residents memorize both parathyroid glands are located within 1 centimeter of the crossing of the recurrent nerve and the inferior thyroid artery. And furthermore, the superior parathyroid is deep to the recurrent nerve, and the inferior parathyroid is superficial or anterior to the plane of the nerve. Right? This association usually rings true no matter where you find that parathyroid. So even if an upper parathyroid gland has migrated inferiorly, it continues to migrate deep or posterior to the recurrent nerve, even if it's in the posterior mediastinum. And a lower gland, as it migrates anterior to the plane of the recurrent nerve into the anterior mediastinum. So those are the two relationships that are constant. This is the real difficult stuff. What do you do if you can't find a parathyroid? What if you do if you found all normal parathyroids? This is the stuff that bothers me in the OR. So you've looked for a parathyroid gland and you can't find it. Where do you go? It depends on which one you're missing, and that's actually a really important thing. You have to ask yourself, well, what am I really missing? Have I really found a lower? Have I really found an upper? What is this? Generally speaking, what I'll do is I'll prove that I've found what I've found, so maybe I'll have a little biopsy of everything, so I'll know, okay, I'm missing an upper gland or I'm missing a lower gland. If I'm missing an upper gland, the first move is I take down the superior pole. Almost always find it by taking down the superior pole. It's going to be behind, above, behind, somewhere tucked in around that superior pole. Also, if there's a tubercle of Zucker candle, that's the recurrent nerve runs right under that, and that's also another place where you typically are not looking that closely because you're afraid that you're getting too close to the nerve or something. So find a tubercle of Zucker candle, look under that. The next place is in the paraesophageal location. This is actually the most common place I find it if I'm re-opping on somebody who had a failed parathyroidectomy. It's almost always deep to the recurrent nerve running along the esophagus. Upper glands are rarely intrathyroidal. It's rare. I see them once every, 600 cases or something. It's like very rare, but they can be intrathyroidal. And also, if they continue to migrate and migrate and migrate, they'll end up in the posterior mediastinum. Fortunately, they usually have a really long blood vessel on them, and you can kind of reel them out, like you're reeling in a muskie or something. Just kind of reel it up. So you can find them without doing a sternotomy. The lower glands are almost always in the thymus. So the first maneuver, if you can't find a lower gland, is you deliver the cervical thymus. You just bring that thymus out through the neck. It's almost always in the thymus. It can also be a little bit more medial than you think it's going to be, more anterior on the trachea. These are also the ones that are in the carotid sheath. And they can be anywhere from the carotid bifurcation down to the bifurcation with the subclavian. More common intrathyroidal one is a lower. So a lower one, if it's intrathyroidal, it's usually right at the tip of the right lower pole, sometimes peeking out just a little bit, but the lower one is the one that's more commonly the intrathyroidal one, and it's usually not that big. So if you have an intrathyroidal parathyroid adenoma, they're usually not huge. They're usually kind of smallish. They can be undescended, which means they're at the skull base above the carotid bifurcation, or they can descend all the way down to the right atrium and the anterior mediastinum. So those are the places where you find missing parathyroid glands. Now, let's say you found 3, you can't find a 4th one. Don't resect the 3 normal ones that you just found and hope that that's okay. If they're normal, leave them alone. Mark them or something like that. If you're going to do anything to them, biopsy them, mark them, but don't take them out if they're normal. Leave them alone. Never resect a normal gland. This is from an old textbook showing the zip code of residence of missing parathyroid glands on reoperations. And the only reason I show this is just kind of show you the territory. If you're missing an upper gland, this is kind of a smaller zone that you're going to probably find it in, somewhere between the takeoff of the superior thyroid artery and where the inferior thyroid artery is, more or less. So it's kind of a smaller area. If you're missing an upper gland, you have less of an area to look in. If you're missing a lower gland, on the other hand, could be almost anywhere. They can be from the carotid bifurcation down to the anterior mediastinum. You have a much larger area to look for. Don't just think you're looking down here if you're missing a lower gland, because a lot of these can be undescended. They can be kind of high. You'll find a little ball of thymus with them somewhere along the carotid sheath. Let's say you found 4 normal parathyroid glands. They all look totally normal to you. Could there be a 5th gland? Well, sure there could, because about 5% of us have more than 4 parathyroid glands. So the first thing I do is I think, did I have the right diagnosis here? Is this really, I'm thinking about that, okay? Make sure you don't take people to the operating room or you don't have the right diagnosis. Sometimes you need to think about that. Remember, for sure, you can have supernumerary glands. They're almost always in the thymus. So you found 4 normal glands, you biopsy those, you make sure they really are parathyroids, and then you take out the cervical thymus on both sides. You almost always find it there. Or they'll say, guess what? You sent us biopsies of 3 parathyroids and a ball of fat. And then you say, oh, which one's the ball of fat? And now you're going back to the last slide that I showed you, and you're looking for one missing gland. Okay. Also, look in the parathyroid. I remember a case I did when I was a junior attending where I was rotating the thyroid over, and I was looking for the parathyroid. I was looking, I'm looking. It's well localized, like a light bulb on a sesame. Maybe I looked for like 3 hours, right? I call my senior partner, and he comes in. He says, well, let me see what you got. I pick my hand up off the thyroid. It's under my thumb. It's been sitting under my thumb for like 3 hours. Makes you crazy. I told him he didn't need to scrub in. Okay. You found all glands are enlarged. What do? You biopsy all 4 glands. It comes back hypercellular parathyroid. In general, you got 2 options. Subtotal parathyroidectomy, which means you leave the equivalent of 1 normal gland on a blood vessel, or total parathyroidectomy with autotransplantation with reimplantation into some other place, at the SCM or the brachioradialis or whatever. It kind of depends on what you're doing. For most of the cases, I'm going to leave some residual parathyroid on its native vascular pedicle in the neck. In those patients who have recurred already, I'm going to get it out of the neck. And those patients who I think need another neck operation in the future, like they have metastatic medullary cancer, I'm going to get it out of the neck. But most of the time, I'm going to leave it on a blood vessel. Complications for hyperparathyroidism are very similar to thyroid, so I'm not going to get into them. Instead, I'm going to give 1 minute for questions, and we're going to roll into the last 2 sessions. Any other questions about hyperpara? Yeah. So there's a study, I think Sam Wells' group did maybe 20 years ago, about 6 weeks is the average, yeah. So if you totally take all the parathyroid tissue out and move it to the arm, just plan on their parathyroid levels being extremely low for 6 weeks, if you're lucky. All right, we're going to talk about incidentalomas because that's where all the test questions are. These are tumors of the adrenal gland found on an imaging study done for some other purpose. If you look at the aging population, the older a person is, the more likely they have an adrenal incidentaloma. Probably about 7% of septuagenarians, 1% of people in the first 30 years of life. Very, very few of these are cancer, 1 in 4,000. And they're almost always found like on a CAT scan for a car wreck or something like that. It's very easy to be an adrenal surgeon. You only have 2 questions to answer. Number 1, is it functional? Number 2, could it be cancer? That's it. It's very simple. If you keep it to that, you see all of this makes sense. So what are the tumors that you can get? You can get tumors of the cortex or medulla. Cortex is where you get aldosteronomas, cortisol-producing tumors, the tumors that cause virilization or feminization, and the adrenocortical carcinomas are from the cortex also. The medulla has the pheochromocytomas, and because of the blood supply to the adrenal gland, all of the mets that come from elsewhere usually end up in the medulla. There's also a bunch of other benign things like angiomyolipomas and hamartomas and hematomas, cysts, and things like that that you can find as well. The screening tests we're going to talk about screening and imaging and treatment for all three of these things, okay? So for aldosteronoma, you're going to start screening with a plasma aldosterone concentration and a plasma renin activity. Blood tests drawn simultaneously, looking for a ratio of about 25 to 30. Lots of aldo, not a lot of renin. And they should be off any drugs that are going to interfere with aldosterone, renin, angiotensin cascade. Then, if you have this positive ratio, you're going to do a confirmatory test, which is either one of these three that I have here, saline loading, fluorocortisone, or captopril. And each of these tests, what you're looking for is that you can't suppress the aldosterone. Why? Because the tumor doesn't care. It's just going to make a bunch of aldosterone. So we're looking for them to fail a suppression test. Aldosteronomas are always small. They're like 5 millimeters to 2 centimeters max. They have bad hypertension. About 50% of patients have hypokalemia. About 50% are normal potassium. About half of the patients who have hyperaldosteronism don't have an aldosteronoma but have bilateral adrenal hyperplasia. That's a problem for us because if we go and take out one side, they're still going to have the disease. So we need to figure out who's going to benefit from surgery, and the way that we do that now is selective venous catheterization. So after you have established the diagnosis, you know they have hyperaldo. They go for selective venous cath, and then if they lateralize, then you can take out the side where all the aldo is coming from. For people under the age of 40, it's probably less important because it's less likely to have an incidentaloma. But above that, I think you just have to do lateralization studies. That is the board's answer. Cushing's syndrome, for the sake of completeness, it's either ACTH dependent or independent for Cushing's syndrome. ACTH dependent means it's something that you got a tumor making ACTH, like in your pituitary, that's driving everything. So for the adrenal gland, we're talking about ACTH independent disease. An adrenal gland just makes a lot of cortisol, doesn't care what the ACTH is. The people with adrenal Cushing's have the classic Cushing syndrome features: centripetal obesity, moon facies, bad skin, buffalo hump, stria, et cetera, et cetera. This is a picture of a guy with Cushing's disease. He's got all of that stuff. I mean, he's got the terrible skin. He's got the moon facies. If we could turn him around, you see the buffalo hump. See, this is one thing right here. Do you see that? He's super happy. Do you see how happy this guy is? It's not because of this amazing surgery that he just had. It's because people with Cushing's are euphoric. They have all of this cortisol. They're super euphoric. When you see them, when you meet them for the first time, they're like, "Hey, doc, I feel terrible." And they look like they're smiling. They're joking with you. They're like the greatest people. And you know what happens after you take out their tumor? Go the other way, right? So they're super depressed. So I always tell people, listen, it's going to go the other way. We got to get them on some antidepressants. And they're going to be on a steroid taper for like a year. 6 months to a year is what I tell them. How do you make the diagnosis? We start out with a low-dose dexamethasone suppression dose. It's a 1 milligram overnight dose of dexamethasone. They go and get their blood drawn the next morning at 8 a.m. and we're looking for suppression of their cortisol. So if you have a tumor that makes cortisol, doesn't care, your cortisol stays high, you got normal adrenal glands, your cortisol goes down. It's a good screening test. It's not easy to get people to take a drug at 11 o'clock and show up for the lab at 8 a.m., so we also use a screening test called salivary cortisol, where we have them spit in a test tube at 11 o'clock at night, and then we have them mail the test tube in. The reason it works is that the blood cortisol equilibrates with the cortisol in your saliva very quickly. And when you have normal adrenal glands, you have a diurnal variation. So at night, your cortisol is supposed to be low. And if you have an adrenal tumor, it doesn't care what time of day it is. It makes cortisol all the time. So you lose diurnal variation. We detect that with the salivary test. A confirmatory test, which is better than both of those, is 24-hour urinary free cortisol. That tells you absolutely, yes, this guy has hypercortisolism. We do CAT scans for these people to do the surgical planning, and a laparoscopic adrenalectomy, just like aldosteronoma, is the preferred operation. I don't do screening studies for feminizing and virilizing tumors. Most of us will do a history and physical exam for that. If patients have signs of feminization or virilization, then we can run all these tests that you see here. Adrenal cortical carcinoma is pretty rare. Things to know about it is that many of them are functional. 50 to 60% are hormonally active. They're not silent. They make a lot of hormones. In fact, they usually make more than one. So I tell people, if you're doing a series of screening studies for hormones for adrenal, if more than one is positive, then it's ACC until proven otherwise. Because usually you don't have more than one hormone elaborated, but ACCs do that, multiple hormones. The most important thing we can do for people with adrenal cortical carcinoma is establish a negative margin. And what that means is that you're doing a multivisceral resection if necessary. And here's why. This is a large study out of the NCDB where we looked at over 2,000 people with adrenal cortical carcinoma. And if you look at the 50% survival, if they have an R0 margin, it's 48 months. If you go to a microscopically positive margin, it drops all the way down to 12 months, 1/4 of the time. So if you give them a R0 margin, that's the best survival advantage there is, better than mitotane and all this other stuff. So if you're going to operate on them, your goal should be R0 margin, because R2 versus R1, basically no difference, 8 months versus 12. Everyone knows about pheochromocytoma. How do you fail boards? Either you needle biopsy it, or you don't rule it out. You take the person to the OR without blocking them with an alpha blockade. What I tell people is that we're going to use, generally speaking, an alpha blockade, and we're going to give a bunch of volume in order to get these people ready for surgery. They're all dehydrated, and they're all extremely norepi, causes their alpha to be so cranked up. You have to block them down. They all get orthostatic hypotension. We give them lots of fluids. Only after they have become orthostatic do we consider taking them to the OR. Never get a needle biopsy of anything. In fact, a general rule is if a radiologist tells you a needle biopsy is the adrenal gland, just say no. That's a general rule. Screening tests for pheo. Nowadays, we use plasma-free metanephrine as a screening test. It's pretty specific. And the urine collection stuff is only a confirmatory test in those cases where we're not sure. There's just a poor compliance with collecting all of your urine for 24 hours. Chromogranin A is not a specific tumor marker. It's a tumor marker I might use for following patients who have known cancer from malignant pheochromocytoma, but not as a screening test. Laparoscopic adrenalectomy is still the treatment of choice, by the way, for pheochromocytoma. Imaging, I still use CT scans. I know that it's a common belief that MRI is T2 bright for pheos, and I think that's true for the most part. But really, the reason that I'm doing an MRI is not to determine if something's a pheo or not, but to plan my operation. I find that thin-cut, high-resolution CT is best for planning an operation. Adrenal cortical carcinoma accounts for a small percentage of small tumors and starts to account for a greater percentage of tumors as the size gets bigger. So sometimes you're looking at these tumors and you're saying, I might take this thing out just because of its size. It's reached a certain threshold where I think the probability of it being a malignancy is high enough. When, like I said earlier, it's easy to be an adrenal surgeon because you're going to have two questions. Is it functional? Could it be cancer? Any functional, like if any functional study is positive, you're going to say, okay, you need to have it out. Or if you think it's cancer by any method, you're going to say, okay, it needs to come out. So size is one of those big things. We say, okay, if it's above a certain size threshold, we're going to say get rid of it. Also, there's imaging features that would make you think something is more likely to be cancer, like actually the next slide I was going to tell you. I'll start out with this one. There are imaging features that make you think it's not cancer, like smooth margins, homogeneity, the fact that it's stable over time. This is an important testable one. Less than 10 Hounsfield units in a non-con CT. That is consistent with a lipid-rich benign adenoma and absence of any regional lymphadenopathy or evidence of invasion. On the other hand, things that would make you think that it is a cancer, a large tumor, irregular margin, heterogeneity, hemorrhage, necrosis. We had a CAT scan last year and it was 3 centimeters. Now it's 6 this year. It's rapidly growing. Adjacent lymphadenopathy. You don't have that less than 10 Hounsfield units. You have a lipid-poor tumor on CT. That's worrisome. Or, of course, any evidence of direct invasion into adjacent blood vessels or organs. All of those things, of course, any of those things would make you say this thing needs to come out. How do you, what pitfalls are there in working up incidentalomas? Not ruling out pheo. Not ruling out Cushing's, even subclinical. So we always rule out Cushing's, we always rule out FEO. Also, as I said before, unnecessary FNA almost never gives you any meaningful information. It's potentially dangerous. Adrenalectomy is not indicated for small adrenal tumors that are hormonally silent, aren't causing any symptoms, and have a low likelihood of being cancer. There are some things like that where the radiologist will call you and say, this is a myolipoma, it's 2 centimeters. You know, that's not something you got to take out. Something that is a very high probability of being a benign thing, it's not doing anything to the person, we will watch. On the other hand, indications, anybody who's making any tumor that hypersecretes a hormone, patient with local symptoms, things that we think have imaging features look like cancer, or when the diagnosis is uncertain. Laparoscopic is generally what we're going to do for any benign thing. For adrenocortical carcinoma, the answer is always open resection. The size of the tumor may dictate whether you can do it laparoscopically or open, though. And so in some people, you know, I think what we generally say is, oh, it's really large, you probably ought to do it open. But for some people, really large means bigger than 6, and some people, maybe that's bigger than 10, or maybe bigger than 4, who knows? So we haven't really set a threshold. We said you better do an open for anything above this size. It's kind of practice dependent. Anytime that you think you're dealing with adrenocortical carcinoma, whether you detect that preoperatively by any of those imaging features that I put up there, or intraoperatively, because you discover that this mass is adherent to the tail of the pancreas and the spleen or whatever. You get evidence intraoperatively that you're dealing with cancer, you convert to open. This is from surgical clinics in North America, I think, from a few years ago, and I think you could find a whole bunch of different algorithms that set different thresholds. And I give a lot of talks to residents, and I ask them, raise their hand if you do it at 3 centimeters, 4 centimeters, 5 centimeters. What is your threshold for recommending surgery in an incidentalloma? It's all over the place. You go, a lot of people practice at 4 centimeters. They say, oh, it's above 4 centimeters, we're going to start recommending surgery. But there are places that practice at 3 and practice at 5. So there isn't like a standard board's answer, and if I was writing boards, I'd probably not pick a number. However, the most recent guidelines that the AAES, that's one of the groups that I'm in, published in 2009, chose 4. So if you want to defend a threshold of 4 centimeters, the most recent published guidelines say 4. Okay, I'm going to give you 3 minutes on on MEN. The first will be with a question. 20-year-old male has hypertension, headaches, sweating, 24-hour urine VMAs are 10 times the upper limit of normal. CAT scan shows bilateral adrenal tumors, thyroid ultrasound bilateral masses that are calcified. The calcium is 11.3. Calcitonin isn't too high, 43. Guy sounds like he's in a lot of trouble. What's the first best step in managing a person who has all of these things? Bilateral adrenal masses, hypercalcemia, bilateral thyroid masses. All right, the best answer is start phenoxybenzamine. Why? Because this guy has pheochromocytoma, hyperpara, and maybe medullary cancer too. So the thing that's going to kill him, the thing that has a chance of causing sudden death, is the pheochromocytoma. So you're going to start that now. You can make a diagnosis of diagnosis of pheo, you start blocking alpha right away. That's the right answer here. MEN1 is an autosomal dominant disorder that leads to the manifestation of multiple tumors in multiple endocrine and non-endocrine organs. Hyperparathyroidism is the one thing that has the highest penetrance. Essentially, all of them get this. It's the earliest onset. It's the first thing. You know what's the problem with this? Is if you see a young person with MEN1, let's say they're 25 or 30, they walk into your office, they have hyperparathyroidism, they don't know they have MEN1, you don't know it either because they haven't manifested any of the other stuff yet. So what I tell people is that if you encounter somebody with hyperpara who's in their 20s or 30s, think this is probably an MEN1 case. Don't just think, oh, it's bad luck, this guy got hyperpara 30 years before everybody else does. All right, so the first thing they get is hyperpara. The second thing they get would be pancreatic neuroendocrine tumors. They can be functional or non-functional. The most common is actually non-functional. The most common functional one is a gastronoma. And then only about 1/3 to maybe 1/2 of patients get the pituitary adenomas that can also be functional or non-functional. The most common functional one is a prolactinoma. They get a bunch of other things. You know what they get? Lipomas. They get tons of lipomas. I see somebody with hyperpara and a bunch of lipomas, I think MEN1. They also get carcinoid tumors, and they're in the foregut distribution, and they can be very aggressive. So they get these non-endocrine things like carcinoid tumors, angiofibromas, cholangiomas, lipomas, they get all that stuff, and then they get the classic pit-pan-para also. MEN2A is, I think, a little bit more simpler to think about. So they get medullary cancer. Almost all of them get that. That is the first thing that develops, and it's also the likely cause of death. So in contrast, MEN1, the first thing that develops, and the thing they all get is hyperpara. MEN2A, the first thing to develop, and the thing they all get is medullary cancer. Only about a third of them get hyperpara, by the way, so a lot of these never have it. About 50% of them get pheochromocytomas. They can be unilateral or bilateral. They can be synchronous or metachronous. You know, I think if they live long enough, they get bilateral. They just have to live long enough and they'll get it. The most common RET mutation that causes MEN2A also causes a funny patch of skin between the shoulder blades called cutaneous lichen amyloidosis. About 5% of them also get Hirschsprung's disease. There's a disease called familial medullary thyroid cancer where you have multiple generations of people who only get medullary cancer and they don't get any of the other stuff. No PHEOs, no hyperpara, no nothing. It's a phenotypic variant of MEN2A. They just have the right mutation on the RET gene, and all they get is medullary cancer. Interestingly, sometimes their medullary cancer is not as aggressive as the other ones. It might wait until age 50 for it to show up. MEN2B is the bad one. They 100% get medullary cancer. They get a really aggressive medullary cancer, often before their first birthday, of metastatic disease by their third birthday, distant Mets by their fifth birthday. It's a terrible disease. If you don't make a diagnosis very, very early, they will not have a good outcome. Just like MEN2A, they get PHEOs, unilateral, bilateral, synchronous, or metachronous. Interestingly, they have this ganglioneuromatosis of their entire GI tract. So from the lips to the anus, they have these neuromas, mucosal neuromas. So it usually is very easy to visually identify these patients as being MEN2B patients. And they all have problems with their GI tract. They all have megacolon and constipation. They're bad feeders. So every pediatrician knows them. Even if they don't know that they have MEN2B, they know that kid. The kid's got lots of trouble. It's always in the hospital. This is a picture of, just to show you, the mucosal scalloping of their lips. They also have a marfanoid habitus. They have really long wingspans, very tall people, and they have a lot of orthopedic things like skiffy and stuff like that. So they're usually a very classic phenotype. All these MEN2 syndromes are caused by a RET oncogene mutation. In addition, if you do the somatic mutations on people with medullary cancers, about half of them also have somatic RET mutations. So RET is kind of the classic genotype-phenotype disease that was diagnosed, the prototypic one. This is published in 2015. It's an algorithm telling you how to manage medullary thyroid cancer, so I thought we'd talk about it in this MEN group here. Essentially, it goes like this. You make a diagnosis of medullary cancer on an FNA. You do your ultrasound. You find that it's medullary. Okay, so you think, oh, that's weird. It's not papillary, it's medullary. So now I have to do some extra stuff. Got to measure calcitonin and CEA. Those are your two tumor markers for medullary cancer. You got to send the patient for a RET oncogene test. You do that in everybody that you diagnose medullary and FNA. If the RET is positive, now you got more work to do. You got to rule out PHEO. You got to rule out hyperpara. You got to know what's going on. And if they have a PHEO, you treat that first. Doesn't matter if they have stage 4 medullary cancer. You treat the PHEO first. If they don't have a RET oncogene test, then you just start asking yourself, okay, how much medullary cancer do we really have here? So if they're RET negative, then you just kind of start thinking, okay, are we dealing with somebody who's got incurable medullary cancer or something we can cure? And the threshold between where you think you ought to start doing a metastatic workup is about a calcitonin of 500. Calcitonin is less than 500. We're going to focus on the neck. We're going to get all this stuff out, and we're going to move on. Calcitonin above 500, you're going to get cross-sectional imaging. You're going to ask the question, do they have widely metastatic disease everywhere? And we should just do something palliative up here so that they can swallow and breathe. So that's the general algorithm for medullary cancer. And just to end, I'll show you this thing with kids. For MEN2B, they should get a prophylactic thyroidectomy before age 1. And for MEN2A, they should get it before age 5. So those seem like pretty young ages, but that is the current recommendation. Okay, I went 1 minute over. But I'm happy to stay and answer your questions. Yes, sir.
In relation to the no-no of biopsying adrenal lesions,
Yep.
if you've ruled out any functionality in the tumors and you have some reason to suspect that it may be metastatic disease,
Yeah.
is it reasonable to do a biopsy?
All right, let me rephrase the question. So, when is it reasonable to FNA the adrenal? Okay. Only after you know it's not a FEO and you think that by doing a biopsy, it's absolutely going to change my management. Like this person has lung cancer and it's stage 4. If I biopsy this, it's stage 4 and it's going to change their therapy. This could be a sarcoma instead of an adrenal mass. I need to know about it. Something that's going to change your therapy. Now, I'll tell you what's funny is that most time it doesn't get to that. They don't say do an FNA. They get a PET scan. They have a known lung cancer, PET positive lesion in the adrenal gland. They're called stage 4. They go through chemo. And then 6 months later, if the chemo went well, you get a phone call and say, there's still a mass in the adrenal gland. Can you take it out? I'm just going to take it out. I'm not going to stick a needle in it to see what the mass is. Same thing, sometimes melanoma is like that too, where there's like the primary tumor is taken care of, there's no evidence of any other disease, there's a hot spot in the adrenal gland, they have known history of melanoma. I think if it's contained within an adrenal gland, it's surgically resectable, do I need to do an FNA before I take that out? I've ruled out FEO, I've ruled out all this other stuff. So sometimes, even then, when you think, if you think to yourself, it's not going to change my management because I'm going to take it out anyway, and I know it's not a FEO, then you don't even need an FNA in that case. But if you know it's going to change your management, it's going to change what's done for the patient, and you know it's not a FEO, then you can do an FNA. Whew. Another question.
Did I misunderstand if you have a high aldosterone-renin ratio, you need to do a bilateral localizing study? If
Yeah.
you have a single, tumor on
I know, it seems crazy. So the question is, you've got a positive screening study for hyperaldosteronism. Your aldo is high, your renin is low, the guy's got it. And you get a CAT scan, and it shows a stone cold normal adrenal on one side and a tumor on the other side. Do you need to do selective venous cath? The answer is yes, if they're over the age of 40 especially. I know, it seems crazy, doesn't it? But these are the guidelines. So the reason is that there's just enough incidence of adrenal incidentalloma that you can be misled. And aldosteronomas are frequently 5 millimeters in size and are below the threshold of a lot of the imaging studies. So there's an unacceptably high incidence of taking out the wrong adrenal gland or doing essentially a non-therapeutic operation if you don't do selective venous cath in that older age group. They always get a selective venous cath. Yeah, even if the scan is normal on one side. All right, thanks.